Can the panelists for this next session on information and management and global surgery metrics come up? So call on Srinath Reddy, Steve Bickler, Emmanuel Makasa, and Kelly McQueen. While they're coming, when I went out for lunch, I saw that there was a wonderful cooked meal. And I told my support team, it's sandwiches. It's A, going to be cheaper, and B, they'll stay awake. And I thought, when you all came back in here, I thought, oh, everyone's going to fall asleep. But what a dynamic discussion we've just had. And I can see that everyone's still awake, so that's great. So it's an hour before coffee, and you'll probably need a sort of a caffeine top-up. But let me introduce the speakers. And I think this session's really important. If there's one thing that the Commission team will take forward, and I think that the list is growing, but if there's one thing that we'll take forward, and that's this whole focus on independent accountability. And as a team, tracking improvement over the next decade or so. I think that's a given. We must stay together and do that. And with that, I'd like to introduce our lead for this metrics work, Russell Gruen. Russell is, or was, a trauma surgeon, general surgeon at the Alfred and the Royal Melbourne Hospital. He's now recently moved on to higher things in Singapore at the Nanyang Technical University and its medical school there. Russell is a professor of surgery and public health. So he's made that paradigm shift, which increasingly others are doing. They're following you. And Russell's done all sorts of things in his career. But one thing I really like about Russell's bio is the picture by the cricket ground. Because unlike, my wife actually was here this morning, she's gone now, but unlike me who has a sort of work-work lifestyle, you've got a work-life balance, which is great, obviously. And so well done. I'd like to introduce Professor Reddy as President of the Public Health Foundation of India. And Srinath is as a visiting professor, he's an adjunct professor, he's an honorary professor, I don't quite understand all those titles, but in various parts of the world, in Emory University, in the University of Sydney, and in the Harvard School of Public Health. And Srinath will bring, I think, to the discussions from his bio, this focus on cardiovascular and the whole link between cardiovascular and surgery. I think it's really important. He also, importantly, has been on the Leadership Council of the Sustainable Development Solutions Network, which was established to assist the United Nations in developing the post-2015 goals for sustainable development. So that's a really crucial thing to bring to the discussion. Emmanuel at the end, and I'm sort of going in the order that, so the bio's here. We've heard from Emmanuel. Emmanuel is juggling all sorts of things with his career as an orthopedic surgeon, and a trauma surgeon, but also a public health specialist. And he's had a number of roles in Zambia. Deputy Director responsible for emergency health services at the Ministry of Health in Lusaka, Secretary General of the Zambia Medical Association, Secretary General of the Surgical Society, etc. But as he said already to us, he's very much in the role of a global health diplomat, not just global surgery diplomat, but global health diplomat. And Emmanuel's played a really key role in this push to have this resolution on emergency central surgery. He's led that push, and that'll happen, as you know, next month. And so that's really exciting. Kelly, it's good to see you again. I last saw you in Ivory Coast. And Kelly is the associate professor at Vanderbilt University. She's an anaesthetist. She's also on the faculty at the Global Health Institute there. And Kelly's very much an advocate as well as a humanitarian. She's been involved over many years in work in various low-income countries, so really understands that context. And Steve Bickler. Steve is similar. Steve is based at in the University of California in San Diego. He's a pediatric surgeon, so it's interesting what we were hearing about the importance of that in this whole advocacy push. And he's also had roles in the WHO and has worked in a lower middle income setting in the Gambia. So it's going to be a rich discussion. Russ, over to you.
Thanks very much, Andy. And there's a free cappuccino for anyone who actually recognises the cricket ground in the background of my photo. You should all recognise the... Thank you, it was the MCG, good guess. So we've learnt from other successful global health programs the importance of a convincing metric. For example, infant mortality rate or maternal mortality rate in advancing the cause. Most of us who are clinicians in the room will be now in 2015 very familiar with measurement in the context of clinical audit and the language of need, demand, supply, and how we as clinicians influence clinical outcomes. What we may not be quite so familiar with is how other people perceive that information, particularly the key stakeholders and decision makers who control resources, how they perceive, understand and prioritise problems, how they in turn relate to and affect health programs, bringing in their own perceptions and biases, their competing interests, and the ebbs and flows of resources as they occur. These are the problem definition and the political economy of programs such as global surgery. And so really, if we're to answer the question, the key questions to advance universal access to care when needed, we've got two questions to ask. One, can we drive progress, and how do we do that? Two, how will we know if progress is being made? Now, to answer those two questions, we put together what is truly an extraordinary group of people. Quite different to most other global health problems. So the team was tasked with the challenge of coming up with and appraising some global surgery indicators, of reviewing the literature, of getting data and modelling data where there's no data available, and perhaps most importantly, feasibility testing and road testing candidate indicators for global surgery, trying to break them, to find out their weaknesses. Could we actually use them? Will they be useful? Will they tell us what we want to know? Will they make a difference? So I'm going to talk a little bit about the challenges in this first and then go through the 6 global surgery indicators the Commission is proposing. And in the challenges, I refer back to this great paper that Tom Weiser, Atul and others with the Safe Surgery Saves Lives group published in 2009 proposing 6 global surgery indicators. And I remember talking to Tom about this paper and him expressing the frustration that little traction had been obtained. And I think they were really ahead of their time in many ways. The first problem is that the global health agencies have not, at this point in time, included much information on surgery at all. So this was a review that we did of the 3 big agencies and their main data sets, and 206 indicators we found. There was none mentioning the word anaesthesia, 1 mentioning the word operation, 2 mentioning the word surgery, compared with 99 mentioning HIV and 206 mentioning child health. The second problem is that surgical data is not systematically collected. And if you look at the ways of collecting health information in the field, in population-based data through household surveys and verbal autopsies, or facility-based data through infrastructure surveys or health service activity measurements, surgery is actually far more complex because it cross-cuts diseases, because it's not easy to diagnose in a household survey and an interview, and because there are various other challenges compared to simpler metrics. So we don't have a good way of systematically collecting it. And another way of illustrating this is the global burden of disease categories, which are listed there on the left, that shows that surgery is represented in all of these categories. So in fact, even when you're admitted to a hospital with diarrhoea, nutritional deficiencies, or neurological disorders or cirrhosis of the liver, a number of patients who are admitted with those diagnoses get operations. They could be diagnostic tests, they might be complications of some part of their treatment, or they might be disease-specific themselves. Surgery is cross-cutting and not relating to a single disease entity, and therefore it's hard to measure. And so, if we're really to want to make a difference, that is working with ministries of health and working with intergovernmental agencies, we need to come up with indicators that are credible, with some time-bound targets that are appropriate for nation-level reporting. We needed a framework, and so our group came up with a framework. This looks a little similar to structure, process, outcome that you might be familiar with, but this is really structure, process, outcome for health policymakers. And it works because it neatly compartmentalises measures into realms of activity and interest. For example, the preparedness indicators relate mainly to health service planning, where facilities are placed, and the capabilities and quality of existing infrastructure. Whereas the delivery of surgery is the responsibility of acute care services in ministries of health, who monitor the clinical activity and have levers to change it. And the impact of surgery relates most importantly to prosperity, to productivity, and to population-based measures that we all hold dear. So we used this indicator framework to then come up with 6 indicators, and I'll go through each one slowly. There are 5 here, and there are 2 in financial protection. The first is an indicator of access to timely, essential surgery. We defined that as the percentage of the population that can access within 2 hours a facility that can do caesarean section, laparotomy, and treat an open fracture. We've talked about these already today as the bellwether procedures, which infer performance of most other essential surgical procedures. We use 2 hours as a proxy for the critical threshold, and we drew that from the maternal mortality literature about the time of the threshold for death from complications in childbirth. We set time-bound targets. 80% coverage of essential surgical and anaesthesia services per country by 2030 to be consistent with the World Bank's goals of 80% of the world's population having access to universal health care by 2030. If you're here at lunchtime, you've seen this map already. It's on the front cover of the Commission report, and this shows the population that does not have access to surgery. The darker, the greater percentage of the population of that country. We clearly have a long way to go. We can measure that. This was done through some clever modelling, and I take my hat off to the modelling group that did it. There are also increasingly interesting ways of doing these analyses. Even simple things like Google Maps can tell you how far it is from one place to another to get by foot or by other form of transport, and they're remarkably country specific, even in low and middle income countries. The second indicator is specialist surgical workforce density, defined as the number of specialist surgical anaesthetic and obstetric physicians who are working per 100,000 population. Not retired, not left the country, not trained, but who are actually working. The target is 100% of countries with at least 20 surgical, anaesthetic and obstetrics physicians per 100,000 by 2030, based on good evidence that there seems to be a threshold around 20 per 100,000 when you look at the actual numbers from the data that we've got that differentiates in the middle the low and middle income and low income countries from the higher income countries, and the first and second centile from the third, fourth and fifth centile. You've already seen this chart, which suggests that there's an inflection, an increase in maternal mortality around the 20 workforce per 100,000 number. And you've also seen this chart that shows what it would take to scale up workforce. The third indicator is surgical volume. Procedures done in an operating theatre per 100,000 per year. Target again, 80% of countries by 2020 and 100% by 2030 actually tracking and measuring it, and 5,000 procedures being set as the critical threshold per 100,000 population. And again, that's based on the Commission modelling group's work that showed very consistently about 5,000 procedures is what is done in the middle and high income countries. The fourth indicator is perioperative mortality. This is an all-cause death rate before discharge in patients who have had a procedure in an operating theatre, divided by the total number of procedures and expressed as a percentage. This is perhaps the most controversial of the indicators, but when you think about it, perhaps clearly the most compelling indicator of safety of surgical care. Perioperative mortality encompasses deaths not just in the operating theatre, but actually in the hospital after theatre. We've chosen procedures as the denominator and not patients and patient admissions because we don't believe that the latter could be collected at this point in time in the poorest settings. 80% of countries by 2020 and 100% of countries by 2030 will be tracking perioperative mortality, and we would reassess with a view to the goals. But we actually know quite a bit about what the perioperative mortality rate is in countries at different levels of development. In this systematic review of 370 publications, amongst emergency procedures, the perioperative mortality rate was approximately 1%. Amongst planned procedures, it was approximately, approximately 10%, and it was approximately 1% amongst planned procedures overall. Some of the issues are at what time in the patient's treatment path you measure it, what you use as the numerator and denominator. We've done some modelling around the best practices for that, and that's in the report. Another key issue is whether you have to adjust perioperative mortality rate for case mix and for urgency. Clearly, based on this systematic review, not many places are doing any adjustment at this point in time. And when we did a 4-country analysis using some convenient data sets provided from Papua New Guinea, Pietermaritzburg in South Africa, Geelong and the national data set in New Zealand, we showed that there is quite a dispersion, a 10-fold difference in perioperative mortality rate overall on the left, and that when broken down by age and by urgency, clearly those two factors have a major impact, but doesn't actually affect the relationship of each centre to each other. So while there's work to do around adjustment, we believe that perioperative mortality rate unadjusted using procedures as a denominator is both feasible and practical and meaningful at this time. Another important issue is how indicators relate to each other. None of these dimensions is complete on its own. John Meara posed this grid from his business school training, and I think it captures the relationship between volume and safety quite well. It's feasible that somewhere could ramp up the volume quickly and do it unsafely. They could be selective about the cases they operate on to avoid the high-risk cases. So one affects the other. But there is a sweet spot where you have reasonable surgical volume, not too much, not too little, and low perioperative mortality rate. And that clearly will be a task for the future, just to find what that sweet spot looks like and how we actually measure it and target it. The final two indicators relate to financial protection. Protection against impoverishing expenditure and protection against catastrophic expenditure, as Gavin has defined, and as the World Bank has defined and is pursuing. And these indicators are really very much aligned with the methods of data collection and analysis and reporting with the World Bank. And you can see from this graph, also in the Commission report, that there is considerable difference in the robustness of countries in different levels of development to offering financial protection for their citizens, both for medical costs in the blue bars and the medical and non-medical costs in the red bars of having surgery between the poorest and the richest quintiles. So while there are many other interesting things that we would like to measure and many other good suggestions, these, we believe, in 2015 are the core indicators for global surgery that will advance us along our cause and are likely to influence the decision makers that control the purse strings and other factors that will determine our fate. This is table 1 in the report that appears on page 2. That's the importance that we've given it. So I return back to Tom Weeser's lament over nothing having changed, and I'm very pleased to say and thank Emmanuel Makasa for his efforts, because late last year he coordinated with the G4 Alliance an open letter in the Lancet about the urgent need for surgical indicators at a critical time when the global reference list of 100 core health indicators was being finalised by the World Health Organization in collaboration with other intergovernmental agencies, and managed to get both surgical volume and perioperative mortality rate into this list, which I think is an outstanding achievement which will embed the process in the future. And so to finish, we had our third meeting in Dubai, and anyone who's been to Dubai has seen the Burj Khalifa, the tallest building in the world. And I say that building just reminded me that if you don't actually look at things closely, and if you don't actually measure, you actually don't know the size of the problem, the lengths you're going to have to go to solve it, or the heights of the mountain you can scale when you do it. Thanks.
Russ, as always, that was great. Really, really clear. I was going to start at this end, but I think we'll start with Emmanuel, because I think it's tremendous that we've already seen something of a success story in terms of the letter, open letter. And it shows the power of evidence, the message, and the messenger coming together. Emmanuel.
Hello. Yeah. Well, thank you so much for the presentation. And I would like to state here that, well, I have just been riding on the shoulders of all of you who have always wanted to do this. I just happened to be at the right place at the right time to just finalize it. And this is true about the letter on the indicators, and it's true about the resolution. So I have just done the last minute bits to it to ensure, and it needed to one of ourselves to be present on the table as a representative of a member state to push this through. And so I thank you very much for everything that you've done so far. And definitely it's not me who has made it possible. It's your effort and your work. And therefore, I hope that from this process and everything else that we've done, we can learn something and ensure that we actually come up with concrete, things rather than just discussions and papers. And I think that goes to what my comments earlier. On the issue of data management, which is what we're covering now, yes, indeed, like you heard from the presenter, we don't have a common system, and we don't even have agreed indicators. So it's good to have the set of indicators that can help us measure things the same way, and so that we can capture this information, and then it can guide us to monitor the progress that we're making, globally, so we see which part of the world is lagging behind. But these are global indicators, which would be very different from what we need at national level. The indicators, like I said, are good for the global picture, but at country level, I'm always going back to country level because I am always interested in my country and I want something done at country level. At country level, besides the indicators that will monitor the global information, there's a lot more information that we need, which goes beyond the indicators. Of course, we need patient-related information about the disease processes, the age, and everything else, the demographic information, and of course, disease information. But of course, we also need information about the human resources. At country level, that information is key. We need information about infrastructure and equipment, consumables, financial information. The previous session just addressed that issue. We also need information about the stakeholders, those who are interested in actually moving this agenda forward or who can potentially impact this agenda. Now, all this information at country level is very key, like I said, not only to help and add or contribute to the global indicators. It's very important to help us to convince those who need to help us to move this agenda forward. Surgeons, anesthetists, you always take information, the type of patient, what anesthesia you use, how much of it, which can all be costed. The information is mostly there. So it's always shocking to see that we don't have information. And yet we are always writing. We never do a procedure without indicating everything about the patient, about what we used, and even the outcome. All that is recorded. So how come we don't capture this information? The information is there. How are we going to convince governments? How are we going to convince partners if we don't have that information? So going forward, it's about working out how best can we capture this information so it's readily available and quickly. We write in books, in paper. We have moved, the information technology has moved. Why are we still using paper? Can we come up with a quicker way of capturing this information quickly? This information is key because it's going to help us convince others to become partners, to convince them to invest into what we're thinking about. The other aspect that I think we haven't really worked on, there are a few surgeons now that have done public health. I see a little bit more because I also had to do public health, so I could see the bigger picture. But we haven't really worked with public health schools. There are plenty of them, and they're dying for information or research areas. How come we've never convinced public health schools to work with us to try and improve the data? They will collect the data for us. They will help us collect the data and correct information. They will also analyze the data and come up with correct information that is very key for us. That's an area that the surgical community needs to try and work on. We really have to work with public health schools because they stand to benefit by, of course, they need a lot of students to graduate and all that, but we also benefit a lot from them because they will scientifically analyze and collect information for us and help us tighten that up. Information, obviously, as you said, is very important for tracking. Tracking where the money is going, whether it's really being used or it's going into somebody's pocket, like my colleague from Kenya said. We need that. Information will be important to track how the money is used in country, or not only the money, a lot of other things are being used. Consumables, not only money that disappears, drugs disappear, equipment disappear, a lot of things are misused. And where in the region where I come from, we always say that we don't lack resources. We have huge tons of resources. What we lack is how to manage those resources and use them properly and target them where they are needed. And information is very key in being able to do that. Of course, evaluation will be another spin-off that will come from good information at country level. And the research, of course, is just data. Yeah, we need to make sense out of the numbers and the figures. And then, of course, interpret it in a way that is convincing to people who are not in our field because we speak different languages, as you heard earlier. And yes, this information will help us make good plans and implement good policies that can close the gaps of the gaps that exist. And of course, finally, it helps us with accountability and transparency. Those are very important. They are things that everybody is demanding of. The population demands that. The people that we serve, the politicians will need to be accountable. They can only be accountable if they have the data, they have the information, so they can clearly explain what has happened, what they have done, what impact it has had, and what benefit it has to the community. So for now, I think I'll end there, and I think my colleagues will add more to it. But sorry, I always look at it from national level because, like I said, I'm a government representative. I look for government and their interests and what they want. And maybe, of course, coming from the surgical community, maybe I can do it. I can play the two together. Yeah. Thanks.
Great. Kelly.
Thank you very much, and thank you to the Lancet Commission for the invitation to be here. But especially, I'd like to thank Dr. Miera and the whole commission for every time they've said surgery, they've said and anesthesia. Thank you very much. So I'd like to spend just a few minutes speaking to the importance of anesthesia and to the relative neglect of anesthesia in comparison to surgery. We've spent a lot of time speaking of surgical care and including anesthesia within that, but there's a few specifics of anesthesia that perhaps not all of you are aware of. Even more than surgery, anesthesia has been neglected in terms of training and resources in more than 85 countries for more than 25 years. And this state of neglect is important because anesthesia is essential across the life course, because the role of anesthesia specifically applies in perioperative assessment and management, pain management, trauma resuscitation and other forms of resuscitation, airway management, surgical intervention, and postoperative and intensive or critical care. As well, for decades, anesthesia has been invested in patient safety. And most often, all due respect to Dr. Gawande and Dr. Weiser, most often anesthesiologists are the guardians of patient safety. It's this focus on patient safety that has significantly impacted perioperative outcomes in high-resource settings. And therefore, a metric that reflects anesthesia and surgical safety is imperative as we scale up both. Now, the indicators that Russell has spoken to, access to surgery, surgical volume, and workforce density all relate specifically to anesthesiology as well. But perioperative mortality rate, if only in the OR or if only in the first 24 hours or the first day, are especially indicative of anesthesia safety. Anesthesia-related mortality rates are high in low and middle income countries. And most importantly to this discussion, these anesthesia-related deaths are most often preventable. And they're preventable through training, vigilance, safety monitors such as pulse oximetry, access to essential medicines, including oxygen, epinephrine or the like, and antibiotics. And therefore, tracking perioperative mortality rate and reporting perioperative mortality rate, even if only in the OR, are really essential to this process because it'll allow benchmarking of new improvements made to systems, including the implementation of new training, safety monitors, and access to medicines. And we know from our experience in high-income countries, when something like perioperative mortality rate or another safety indicator is benchmarked, it improves patient safety. Thank you very much.
Yeah, Kelly, I always thought that the pediatric surgeon was the guardian of the patient. I would like to start by really thanking everyone for having me on the panel. I consider it a great honor. As I listened to all the talks today, clearly the recurrent theme is the importance of and the need for indicators. We began today listening to Andy Leather tell us how Richard Horton had given him the charge to develop indicators. We heard David Waters talk about the postoperative mortality rate, and it's important in the World Health Assembly Amendment. And then Emmanuel Makasa talked to us about surgical workforce and why is it so important to track the workforce. And And then this afternoon, Gavin talked about surgical financing and expenditures. So why are indicators so important? Well, you can't fix something if you can't track it or you can't measure it. And I think really the problem with global surgery has been that surgical conditions and their impact have been invisible. And the great contribution of DCP3 and the Lancet Commission has made surgical conditions more visible. But one of the great contributions, I'm sure when people look back at the Lancet Commission, is their contribution on clearly defining metrics. And I think the importance is that these metrics are collectible, they're traceable, and probably even more important, they're going to make people accountable. I couldn't agree more with what Emmanuel said, is that the challenge of the Lancet Commission is really to take things to the country level, because it really doesn't make that much difference overall, but unless we really act at the local level, we're not going to really see any changes. So I'd really like to congratulate Russell and the Commission for the developments of these surgical indicators. I look forward to helping to implement them, and I'm really excited to see how they're going to improve over the next 15 to 30 years. Thank you.
Srinath.
Thank you very much. There is no doubt that health management information systems are the GPS of the overall health system. And they together provide the course coordinates, in this case, for better surgical outcomes in terms of accessible, affordable, and appropriate care. We do need access to valid as well as representative information that not only informs and influences policy and practice, but also results in greater impact and equity. This has been the key theme from the morning session. So when we're looking at impact, we're looking at health outcomes as well as quality measures. When we're looking at equity, we're looking at access as well as affordability, and all of these have been captured in the 6 indicators. And I think these 6 indicators are entirely appropriate, and I think they're very helpful for moving us forward. But I'll come back to them a little later. So clearly, we are looking for various types of information, burden of disease estimates, in this case, looking at national aggregates as per the global report. But clearly, in large countries like India, you need disaggregated data. You need the data to be disaggregated by geography, by socioeconomic status, by gender, because if you're ultimately looking at health equity gaps and how to bridge them, then a single national aggregate indicator will mask some of these inequities. Then second, we are also looking for information on health service capacity and demand responsiveness, and some of these indicators do capture that quite well. We are looking at unmet needs, which also includes lack of timeliness, because something that is delayed, even if delivered at a later date, is still an unmet need at the earlier stage. We are looking at inappropriate care, because in some cases, the care may be actually inappropriate, both in terms of the quality, the nature of procedure performed, or even it could be an example of induced demand, quite often fueled by private insurance systems or state-funded private insurance systems, and so on. So we are looking at both unmet needs and ill-met needs. We are looking at cost of care and affordability indicators of care. We are looking at facility-based as well as population-based information systems, and these have been described very well in the report with their respective strengths and weaknesses. But ultimately, whatever be the sources of information, we need to configure these information systems so that they not only provide estimates of burdens, but we can also measure, monitor, and reduce the 3 delays that have been spoken of in the morning. If ultimately those 3 delays are really responsible for poor quality of care and poor health outcomes, the information systems must tell us how each of those delays is actually being addressed by reconfiguring the health system and how those delays are actually being attended to. We do need to link our health management information systems to comprehensive, integrated, continuous care, which seamlessly stretches from primary to tertiary care. Again, one of the lessons that we have learned from the MDG experience, despite the fact that we have had some commendable successes, is that vertical programs however nobly intended and however well designed, cannot be force-fitted into a weak health system. They'll only end up fragmenting the health system further. Therefore, it would be imprudent on part of any surgical constituency or surgery and anesthesia constituency to say that we must have an independent stream of health care within the overall health system, disconnected with other elements. And therefore, even in the health management information system, the information gathering as well as analytic framework must also be integrated with other elements of the health system. It must definitely have a distinctive identity, but not necessarily stand alone. Using the cricketing example from the MCG, we're not only looking at the individual champion batsman, but we're looking at the entire team. And that's where we need to build in that element of complementarity. And therefore, we need to also reduce the time between data collection and policy response. So we need more real-time data and rapid analytics. We can't have data which are 5 years old and expect policy to respond to that with any sense of appropriateness. And finally, we must also recognize that we are dealing in many of these countries, low and middle income countries, with mixed health systems, which are still evolving. And therefore, how do we actually bring in both the public and the private players into health management information gathering and appropriate reporting rather than just delivery of health care? So how do we knit information from all of the players that are available in the society in order to get the best possible estimates for better monitoring? So these are some of the challenges that we do have. And in terms of particularly the facility level data, much of the private care, much of the care in many of these countries is being delivered by private sector, so we need to bring them in one way or the other. Just to give an example of India, how some of these challenges are being looked at. We do have demographic surveillance sites. 3 of them are very advanced. We have 20 cohorts which can actually become good demographic surveillance sites, 20 plus. We have registries for cancer, trauma. We have for cardiac surgery and interventional cardiology, a contested area where cardiologists and surgeons may actually be claiming territory from each other. But also in terms of transplant procedures and so on. We have verbal autopsies. We have the Million Death Study. We have a health management information system which is linked to the National Health Mission, which is now trying to gather district-level data in public sector facilities. The private sector is left out again here. In terms of private sector, we can use the Clinical Establishments Act to mandate reporting. We can also use the large number of private medical college as well as public medical college hospitals, as well as the number of private hospitals which are linked to the National Board of Examinations, which is the parallel postgraduate training program, all of which will have to report on their specific surgical load, anesthesia load, when they're applying for primary accreditation or secondary accreditation, and list the types of procedures that are performed. So there are a huge amount of data sets that are lying unutilized, as our colleague has said, which now need to be looked at. So we also have insurance programs, which are now state-funded insurance programs, particularly intended for the vulnerable sections, but are covering large segments of the population, either a national insurance program, which is mainly for the informal workforce, which is 93% of Indian workforce, or state-funded insurance programs for tertiary care and secondary care, all of which tell you about what kind of hospitalization procedures are being performed, particularly the surgical load. Now, the challenge is, how do we integrate all of these data sets? And therefore, we really need a mechanism by which all of these disparate data sets are appropriately integrated, and therefore we may need big data analytics and some capacity built in that area for integrating and absorbing all of these data. But at the same time, we also need to make sure that we can appropriately utilize technology in a suitable manner to generate real-time data from the field and from the facilities, both, right from the community and the primary center level, as well as the facility level. And we do have now a lot of technologies, handheld tablets, which are being used by frontline health workers, for example, one point-of-care diagnostic device with decision support systems developed by our own foundation engineers, now being used in the state of Jammu and Kashmir for maternal and child health. All of them can be used very usefully in the field for generating field level as well as facility level data. and electronic health records as well that can be created in order to really build in a framework for nationally representative and state-wise disaggregated real-time data, which can be really influencing policy. All of this cannot be done overnight. We recognize that. But as I tell my colleagues, if the perfect is not immediately possible, then perfect the possible, and then try to make the perfect possible. So in which case, you try and identify what are immediately areas which are already there, which can be strengthened and better integrated while you're trying to set up more sturdy systems which provide better integration. Finally, returning back to the 6 indicators here, I do agree with all of them, but I do have a small bone to pick on the responsible entity. Whereas for the indicators related to access, surgical workforce density, surgical volume, and the perioperative mortality rate, the Ministry of Health has been positioned along with facilities for protection against impoverishing expenditure and protection against catastrophic expenditure. The only responsible entities that have been listed are World Bank, WHO, USAID, for both of those categories. Where are the national governments? If the national governments do not take ownership, how are they going to show any commitment to this, either in terms of delivery or in terms of accountability, which has been the slogan of the day? So we do need to make the national governments responsible for the data collection as well as accountable for it, even if there are external agencies monitoring it and collating it. Therefore, I would very much salute the global effort, but suggest that this should be firmly anchored in the setting of national health system strengthening. Thank you.
I'm going to have to play the tape back again and again after all these panel discussions, because there's such a richness there. Thank you all so much. We've got time probably for no more than 3 questions. And I see a question here. Young lady first.
Hi. Can you hear me? Okay. Hi, my name is Adia Benton. I'm an anthropologist. And I've been hearing some things that it's not really a question as much as a comment, based upon multiple panels and not just this one. But I'm curious about how politics has been conflated with politicians, when all I hear about is politics operating on multiple levels, which is who collects data, how is it used, who are the consumers. And I am moved to cite a British social anthropologist, Marilyn Strathern, who says, when we talk about accountability, we've become obsessed with accountancy and turned those things and turned this question of accountability, which has many qualitative components, into accountancy. There's nothing wrong with accountability. There's nothing wrong with accountancy. But to conflate the two is also to divorce the question of politics from all of these different issues. That being said, I worry that we fetishize the data. I come from a history of monitoring and evaluation before I became an anthropologist. And I've been wondering how clear you can be about the ideologies undergirding not only the drive for collecting data, but how we come to interpret and analyze it. And Professor Reddy made so many interventions in that regard, which is what kinds of ideologies are aligned with the data and the ways that it's collected. How do you incorporate the question of equity and social justice in ways that are explicit in how you both collect, analyze, use, produce, consume, and report on these data processes?
Russ, do you want to pick up on that? I think it'll also be something that comes out after tea, actually, in some of the way forward discussions. But I didn't want to I wanted to do immediate feedback.
So I'm sure that I would lose any argument about semantics with an anthropologist. But to pick up on the accountability and the person versus the process, we have always taken the view that responsibility rests with people, and that people are actors and not organisations, and that therefore communication of information in this case between people to people who are going to make decisions and influence change is what's really critical here. And our view on the political economy of healthcare is really the way that important people in their organisations can influence programs, both positively and negatively, through their various other competing priorities, through the way they see the world, and through the way they accept, understand and operationalise information. So this is very much about a relationship building exercise, and this facilitates a conversation for us, and that's the primary goal of metrics and information for us. Now for the second part of the question, I think I'll handle that to somebody else.
Did you want to say anything else? No. I think let's move on. Question at the top there, sir. Yes.
Alan.
Thank you very much. Alan Merry from New Zealand and also a board member of WFSA. I think these definitions are fantastic because we have been seriously lacking, as has been said, internationally agreed standard definitions, particularly the perioperative mortality one. Interestingly, we did have two, now we have one slightly different. But actually, we're not measuring them. And the starting point, this is fabulous. I don't think we need to fuss about, the point is it's standardized, it's reasonable, it's great. The challenge is getting it measured. And I think that the starting point is actually to get high-income countries to measure it. Actually, they're not quite so easy as you think. I collected the data for Auckland City Hospital for the provider numbers for the paper by Tom Weiser. And actually, it took me 6 months for one hospital in a high-income country to find how many surgeons we had because of the complexity of the employment model. So my question is, can we have some process or undertaking to obtain this information for even half a dozen high-income countries that will set this agenda firmly in place and will then give us a good moral basis for collecting it from other countries?
Who's going to pick that one? They're all looking rather shy.
Well, the question is obviously targeted at developed countries. I come from the developing world, but we are willing to try. Even there, we don't have to start from the developed world. We are willing to try, and we are very keen to have measurable, comparable information or comparable indicators, so that it's easier to speak the same language and to assess things properly when we talk about these things at the global level. As you know, the resolution that will be adopted at the Assembly has a timeline with specific, expectations from the member states as well as from the WHO Secretariat. There will be need for reporting on those things. And so we would need certain metrics that are global. Already we have some in the GISC, but there's need for more so that we can be able to, when we present a report or when the member states come together to discuss the progress on what they have done on surgery, it will be easier to understand each other.
Russell,
I just want to make a quick comment that Professor Mary's being very modest, I think, in making that comment, because New Zealand has, by far and away, the most complete, outstanding measurement of perioperative mortality and reporting of it through their Perioperative Mortality Review Committee, the chair of which, Leona Wilson, is here, and she reports to Alan as the chair of the New Zealand Quality Committee. And without their national data set, most of our modelling exercise and the key messages would not have been possible. So I think, Alan, thanks for your comments, and I do think all high-income countries should follow New Zealand's lead.
Great. I think we're going to have to stop there. And let's just show a hand of applause for. But before you move, rather like Justine this morning, before you move, I just want to acknowledge the role of 4 individuals. John, did you do this earlier at lunch? I don't think, no. And that's the writing team. And the writing team is a remarkable team of 4 individuals, and I'd actually like them to stand up. Sarah Greenberg, Anna Dare, Joanna Reisel, and Nakul. You see, When you get into your sort of late 40s or early 50s, you need a little sleep, and so we can just, these guys don't, and they haven't had any sleep for about 6 months, and so their role has been quite outstanding. I've never seen such commitment as with these 4 individuals, so thank you very much. It's time for tea.